Acum am discutat despre boli mai rare. Este plăcerea mea to invite my co-chair, Professor Amin, to talk to us of a very frequent disease in our days, steatotic liver disease associated with metabolic dysfunction.
Thank you very much. Thank you for invitation. I was honored to be with you in your Congress. My topic today will be from NAFLD to MASLD, pitfalls of a new definition. First, this is my disclosure. As we know, the global prevalence of NAFLD or MASLD is increasing. It affects about 1/3 of the population, and in the Middle East, where I belong, it is about 32%. It is not only in the adults, but also in children. It affects about 7 to 10% of the pediatric population, which is a very great burden. And as we know, NAFLD is not a liver disease alone. It is a multi-system disease. The main cause of death in this patient, actually before the development of cirrhosis, is cardiovascular mortality. Also, it increases the risk of CKD, osteoarthritis, polycystic ovary, obstructive sleep apnea, among others. And as we know, the metabolic factors are great in these patients. It is associated with obesity, diabetes, insulin resistance, hyperinsulinemia, hyperglycemia, adipose tissue dysfunction, decrease in adiponectin, increased leptin, and increased cardiovascular risk. Also, these metabolic risk factors increase liver-related events such as liver cell failure and decompensation, diabetes and obesity compared to those with no metabolic risk factors. And as we know, previously the definition of NAFLD is more than 5% of hepatocytes affected by steatosis after exclusion of significant alcohol consumption, which according to the EASL more than 20 grams per day in females and 30 grams per day for males, and also after exclusion of other causes such as viral etiology and drug-induced. And not all patients behave the same. Most of the patients are simple steatosis or NAFLD, which is slowly progressive, and about 10 to 20% who are progressive. That's the presence of itis, steatohepatitis, that predicts the progression of the disease into fibrosis and hepatocellular carcinoma. Is NAFLD the right name? Actually, it is, as we said, it is a disease of exclusion. You have to exclude all other causes of chronic liver disease before you describe the patient as NAFLD. We need a diagnosis with a positive criteria because this disease can coexist and can exacerbate the other chronic liver disease such as hepatitis B or C. Also, this non-alcoholic leads to lack of awareness, public health response, and underfunding. And also, one-size-fits-all phenotype is inappropriate for this disease. If we look to these three varieties of patients with different contribution of genetic, environmental, and metabolic dysfunction, these three patients are different, so the response to therapy will be different. And so the problem with the old name, it does not capture the heterogeneity of the patient population with regard to drivers, disease modifiers. It does not define the individual phenotype for target therapy. The trial is based on pathology, not the driver, hence poor response to the trial medication, and it also discriminative or stigmatizing disease. So for all these factors, leads to the growing dissatisfaction with the current nomenclature. And the change of the name, it is dating since very early in 90s by either authors or by societies until the 2020 Islam Ital and the international consensus suggested the name of MASLD, metabolic dysfunction associated fatty liver disease, and they put an algorithm for its diagnosis. You detect steatosis by imaging or by markers or scores if the patient has overweight or obesity more than 25 body mass index and the initial more than 23, he is MASLD. If the patient is diabetic, he is MASLD. If he is neither of them, you can also diagnose MASLD in this patient in lean body weight in the presence of 2 metabolic risk factors, 5 well-known metabolic risk factors with the addition of another 2, that is the HOMA-IR more than 2.5 and high sensitive C-reactive protein more than 2. So if the patient fulfill 2 metabolic risk factors and he is not diabetic or obese, you can still diagnose MASLD. MASLD proposed by Islam Italy include patients irrespective of the alcohol intake. And so while MASLD was accepted by some, concerns were raised about mixing of etiology, as they include those who consume alcohol, they include those with hepatitis as well as they are still using the fatty, which is stigmatizing for some of the peoples. And this will impact the natural history of the disease. If we compare the 2 definitions, the NAFLD and versus MASLD, NAFLD exclude patients with significant alcohol intake, exclude patients with other chronic liver disease B and C, while in the NAFLD it is MASLD diagnosis, it is included in the definition. So, what is else? One area of particular concern is in changing the nomenclature is the change in the diagnostic criteria, which may criticize the development of biomarkers and therapeutic development. So for this concern, a multi-stakeholder effort was done under the umbrella of the EASL and the American Association and other societies, and put a consensus. And these are all involved in the Delphi consensus on the new nomenclature of liver disease. And they put this definition of steatotic liver disease under a big name of steatotic liver disease. They put different classification according to the underlying predominant pathophysiology. If the patient has a metabolic risk factor, and this metabolic risk factor, they put the criteria of the metabolic risk factor, and you have to acquire only one of these metabolic risk factors, which is body mass index more than 25, or with the circumference reflecting the central adiposity, impaired pre-diabetes or diabetic, hypertensive, hyperdyslipidemic, HDL, and triglycerides. If he has one with this, you can diagnose MASLD. And they also put a pediatric criteria for the metabolic syndrome, and also if the patient has one of these criteria, you can diagnose MASLD. They put another new entity in patient who consumes alcohol more than 20 and less than 50 in females, and more than 30 and less than 60 in males. This can be under the combined etiology of metabolic as well as alcoholic, and it is alcoholic liver disease, which is a new entity. And I think this disease will be more progressive than the MASLD alone. If the patient have significant alcohol consumption, that is more than 50 and more than 60 in females and males, this is alcoholic liver disease, irrespective of the presence of metabolic risk factors. If the patient has no significant alcohol intake and no metabolic risk factors, then you have to search for another cause for the steatotic liver disease. And you name the steatotic liver disease according to the etiology, for example, if it is deli or other. If you didn't find any etiology, any underlying disease, this is cryptogenic steatotic liver disease. And this cryptogenic liver disease may be an early MASLD, which needs follow-up to detect this development of metabolic risk factor to reclassify the patient as a MASLD later on. So what about NASH? NASH is very important in the previous definition because it has a prognostic implication. The presence of NASH predicts the progression to fibrosis and cirrhosis. Second, it is one of the requirements for approval of drugs for treatment of NASH. The FDA put 2 targets for drug approval, either NASH resolution without fibrosis progression or fibrosis improvement without NASH improvement. So we have to keep NASH but replace non-alcoholic by metabolic dysfunction. So NASH will be MASH. So this is the algorithm after addition of the MASH under the MASLD. So what about assessment of the patient? The change is only in the nomenclature. The risk stratification as the diagnostic criteria and risk stratifies the patient is the same. There is no change. It is the same of this patient, and this is the new EASL algorithm for this patient. If the patient is diabetic or obese with one metabolic risk factor or persistently elevated elevated liver enzymes, you have to assess or risk stratify by one of the non-invasive tests, which is simple scores using simple lab test of the patient, which is FIB4. FIB4, if it is less than 1.3, this patient is a very low risk. You have to insist on lifestyle modification and reassess in 1 to 3 years according to the presence of risk factor. Keep in mind this low cutoff point is different because one of the items in the calculation is the age. So with the patient after more than 65, the low cutoff will be 2 instead of 1.3. So the age determines the low cutoff to be used. If they have more than this, you have one of two pathways. After either you have to wait for 1 year of lifestyle modification and reassess FIB4 if the patient is on the low side of the intermediate range, 1.3 to 2.6. If it is on the high range, it is better to do, if I prostate, another non-invasive test for assessment of this patient. If it is more than 8, refer to hepatologist. How to compare MASLD versus MASLD? What is the difference? The main difference of them, the 7 criteria of the metabolic syndrome, the requirement of 2 metabolic risk factors, not 1 metabolic risk factor, compared to the 5 metabolic risk factor in the MASLD criteria, and you need only 1 criteria to diagnose this patient. And the subtypes of the MASLD of the NAFLD patients under the post-nomenclature, it is either obese MASLD, type 2 diabetic MASLD, or lean MASLD. While here it is only one type, and if the patient has more alcohol consumption, there is a new subtype which is mild alcoholic liver disease. Is this the end of the story? Actually not. Because this is a letter to the editor from NAFLD to MASLD, Bronx and Pitfalls of the new definition from Dr. Zubair, as he describes that the presence of one cardiometabolic risk factor in the general population is very high, about 90%. And those above the age of 45, the presence of one of these cardiometabolic risk factors already present, 85% without steatosis. Second, in contrast, 50% of individuals with MASLD based on overweight, they have insulin resistance by home MRI in only half of patients. So there is a discordance and relative low specificity of using comorbidity as a surrogate marker of insulin resistance. Also, the proposed criteria using one metabolic risk factor is a more relaxed definition, which leads to a higher proportion of patients to be included and has a low positive predictive value. Many patients with different types of diabetes, for example, type 1 cystic fibrosis, will have no insulin resistance and may have steatosis. What is the pathophysiology of this patient? Also, the term steatotic makes confusion to the general population because more or less it is a medical term rather than the previous one. Also, another paper criticizing the MASLD versus NAFLD criteria, they propose it has lack of specificity, power performance less, overdiagnosis, lack of consideration of the lean body weight, the inappropriate pediatric criteria, increased heterogeneity, and so we have three nomenclatures by 3 different criteria of diagnosis. Those of NAFLD, which consider patient after exclusion of significant alcohol consumption and exclusion of all other disease. The MASLD criteria, either patient with steatosis, obese, or diabetic, this is MASLD, or fulfilling 2 of 7 metabolic criteria in lean body weight, this is considered. And ending with the MASLD criteria, the presence of 1 metabolic risk factor in a patient with steatosis. And this is a study correlating the 2 different terms, whether they are the same and diagnose the same patient or not. In the survey of over 7,000 patients using the FibroScan and the CAP of this patient, they found that the big umbrella of steatotic liver disease is present in 34.2% of patients. 99% of these patients, 31.3%, fulfilling the criteria of MASLD. And the overlap of the 2 definitions is present in 99%. So it do well for diagnosing patient with them. And this is recent, another paper in July 24, comparing the similarities and differences between the 3 definitions. Actually, the NAFLD was diagnosed in 38.01, and by the MASLD criteria, it is diagnosed in 41 because it includes patients with alcohol consumption, so it is somewhat higher level. The MASLD criteria is more or less the same as the NAFLD criteria, 37.9. And the more important, those with advanced fibrosis as F2 and more, which is significant for progression of the disease as detected by the FibroScan more than 9.7, it is the same by applying these 3 criteria. So we have in conclusion 3 definitions, all with positive and negative, we can criticize. We are waiting for the, I think we still, the coexistence of the 3 terms, NAFLD, MASLD, within the academic discourse is anticipated until the implementation of the new ICD code by the WHO and rebranding of NAFLD and NASH by regulatory agency in the United States and European Union. And this is our country. You are welcome any time.
Thank you. Thank you very much, Professor Amin. We have a slight change in the program. There will be an online intervention, so we'll leave the questions at the end of the session.
Thank you very much. In remaining session with NAFLD, face deosebită plăcere să-l invit pe prietenul nostru, profesorul Klein de la